All right, looks like we've got everyone here. I've got the pleasure to introduce Dr. Richison. So, Dr. Richison is an assistant professor in the UMS Department of Psychiatry and the associate program director for the Addiction Medicine Fellowship. She completed her 4 years of psychiatry residency training here at UMS and then went on to Vanderbilt for her addiction fellowship. In addition to her role in the Addiction Medicine Fellowship, she is very involved in our residency training program. She teaches on our addiction psychiatry rotation that our PGY1 residents rotate through. We are very excited to hear her talk on harm reduction for opioid use disorder. And with that, we'll give the floor to Dr. Richison.
Perfect. All right. Thank you, Dr. Burrows, for that introduction. So again, I'm Abby Richison. I'm one of the assistant professors here at UIMS and one of our addiction psychiatrists. So today I'll be talking about harm reduction for opioid use disorder. And I hope I can get this working because I do want to start this off with a video. So this is a video of On Point, New York City. So this is a overdose prevention center, used to be called Safe Injection Sites. I had the opportunity to meet with Sam Rivera and he actually showed us this video, but it really highlights harm reduction. So hopefully we can get this working and the sound all right.
I've had a lot of like blood infections, and I don't know if you guys can see the back of my neck, but I have a giant scar from I have two rods. I have a rod here and a rod here, and they go down my back and my C-spine and my T-spine. I have pieces of my hip and my neck, and that's all from using dirty needles, reusing my needles, reusing the cotton pieces. I don't know why I can't stop. You know what I mean? Like I don't feel normal if I'm not on like some substance because I guess I've medicated myself for so long on that substance. I mean, not just like living in reality because of something that I've been through. Like, yeah, I've been through shit like as a kid, but I don't blame, that like on like my life right now. This is different from a needle exchange because a needle exchange just gives you supplies and then you leave.
The United States had over 100,000 overdoses last year. People talk about recovery, dead addicts don't recover. They're not here, right? 633 individuals, unique individuals using our sites in 6 weeks. 6 weeks. Over 6,000 utilizations of the site. 6,000 in 6 weeks. New York City had a number they were putting out there, hoping that we would be able to have 130 individual overdose interventions in the first year. We have 124 in the first few weeks, or less than 2 months. Behind those numbers.
Okay, so I'll stop it there because I know we only have 20 minutes with this. Yeah, so that's Sam Rivera and talking about shortly after that they opened On Point and looking at their numbers now. So they opened in November of 2021. They have served over 4,000 participants, had over 1,400 overdoses, interventions, and over 2 million units of hazardous waste that's been collected from this. So when we think about harm reduction, there are a lot of different kind of terminologies, thought processes of it, especially depending on if your background is social work versus medicine. And so here's a few public health relations too. So a lot of this is focused on human rights, as well as decreasing risk, especially when we think about in medicine, decreasing medical risks. So strategies and ideas built on respects for persons, improving health and functioning. Really the way that I like to think of this, and y'all might hear me say this a lot, is about meeting people where they're at. So a lot of harm reduction is just about someone might not be interested in abstinence, but meeting them where they're at. How can we decrease the harms with where you're at right now? And why does this matter? So as Sam Rivera was saying, in 2022, the overdose rates surpassed 100,000, which is the highest number that we've had in the US. As I'm sure everyone has heard about, with the opioid epidemic, especially with fentanyl being around now, and we can see that increase in the synthetic overdose deaths, as well as there's now becoming an increase with the psychostimulant deaths too. So we have increased overdoses, as well as a pretty significant treatment gap. So only 13% of people who have a substance use disorder receive any treatment, and this includes medications, counseling, meetings, residential programs. So only 13% of those receive treatment. And so a lot of this is about reframing outcomes, because I'm sure you're thinking, well, is this because people aren't interested in treatment? And there has been, so this is from the same study, the National Survey on Drug Use and Health from 2021, and they found that 95% of those who had a diagnosis of a substance use disorder in the past year, 95% of them did not feel that they needed treatment. So again, this is about meeting patients where they're at. So reframing our outcomes from the more abstinence and retainment base into something that is more harm reduction. So decreasing those acute harms. This means decreasing complications, trying to decrease use, increasing their engagement in care. Oftentimes, at least from my experience in the clinic and everything like that, you meet patients who are interested in decreasing use or decreasing the harms, and often with more engagement, those change with time to more engagement in care or abstinence, or not, So, speaking particularly about opioid use disorder, you want to think about 4 different dimensions. This can also apply to other use disorders, so like stimulant, alcohol. However, just for brevity, I'm only going to be talking about opioid use disorder. So 4 dimensions include medications for opioid use disorder or mood, infectious complications, so how can we decrease the risk of infection, overdose education and naloxone distribution, and then addressing social determinants of health. Also, for the sake of brevity, I won't be talking about the social determinants of health aspect, but if anyone's interested in talking more about that or learning more about that, please reach out to me afterwards. Starting with our medicines that we have available for opioid use disorder. So we have 3 that are FDA approved. So methadone, which is a full agonist, buprenorphine, which is a partial opioid agonist, and then naltrexone, which is a antagonist. So these have been shown to decrease the risk of overdose, as well as increase retainment and help patients with abstinence. But even for those who are not interested in complete abstinence, or let's say they want to continue using alcohol or stimulants or something, these have also been associated with less injection use, leading to less infectious outcomes and complications, less criminal behaviors, and less overdoses. Gonna put an asterisk by overdoses, because naltrexone being an opioid antagonist, you actually can end up seeing a little bit more of that. So something to consider when you see patients who are interested in treatment, in making sure that they know the risk benefits of what's available. And this isn't quite, medicine for opioid use disorder, but since I talked about it at the beginning, I did want to have a separate slide just for this too. So overdose prevention centers, again, they used to be called safe injection sites. That's what I was used to hearing. And so these sites are where people can go to use their substances in a safe environment. They have not only, needles for them to use, cotton, fresh water, they also have other resources available there, focusing on the person as a whole, and just be able to offer a supportive environment. So these have been very much studied in other countries. Here in America, we only have, last I looked, 2, and those are both in New York by Sam Rivera. From this and from looking at other countries, you do see a decrease in overdose, less infectious complications, actually more entry into treatment. Typically, you have people coming to these programs and they hear more about treatment. are being approached in a non-judgmental, less stigmatizing way, so they're able to get their foot in the door from the healthcare system, because it can be extremely stigmatizing for those with substance use disorders. And you would think a lot of places do not want to have a program like this in their community, thinking, well, I don't want these people around and there's going to be increased drug use. However, they actually found decreased street heroin use because they have a safe place to go and use, and decreased criminal activity in that area. Highly recommend everybody watch that video, that 12-minute video, because he even talks about the amount of syringes that were in the parks beforehand have significantly decreased, and they're actually able to open those parks now around this OPC. Okay, so this leans a little bit into the infectious. So a lot of this is, you know, being able to offer syringe needle access depending on where you are. Some places that could be considered illegal. So we do have some harm reduction available here in Arkansas. I have some links to that at the end of this, but having syringe needle access decreases the transmission of HIV and hepatitis C, as well as, again, increasing engagement and care for substance use as well as infection disease. Oftentimes, you know, you just want to ask the patients about their practice use. So do they have fresh water? Where are they using it? Trying to avoid the more high-risk areas to decrease the risk of emboli and hemorrhage, as well as talking to them about not using needles after other people, not reusing needles. And then for patients who want to continue to use IV, you know, offering them screening as well as prevention for certain infectious diseases. And then lastly, overdose education in naloxone. So originally when you first were able to get naloxone, you needed a script from a pharmacist, and then all you had to do was go and ask a pharmacist for it. Now the FDA has approved an over-the-counter one. The biggest concern about not being able to freely give out naloxone was this outdated thought of, well, if they know they can save themselves afterwards, they're just going to use more. However, studies have shown that there is no increase in compensatory use, and understandably, you see a reduction in deaths, less ED visits or emergency department visits, and decreased medical costs associated with this. So here are some of the resources that I spoke about. The link on the bottom is to On Point, New York City. Here in Arkansas, we have Narkansas, super cute app, so I talk to patients about that. That has a lot of harm reduction stuff on there, as well as for some patients, talking to them about never use alone. So it is this number that someone can call. So if someone is using alone, they call this number. There's someone on the other line who keeps on checking in on them. And if they become unresponsive, then this person will call an ambulance for them. And here are my references. And does anybody have any questions? I hope I did okay with time. Yeah.
Thank you, Dr. Richison. I'll be keeping an eye on the chat there. If anyone has any questions on Zoom, we'll be on the lookout. I'll start us off with one. So for folks that are practicing in an inpatient setting, and I know our PGY1s rotate with you now, and a lot of us, you know, PGY2s, 3s, 4s, we didn't get the opportunity to work with you. And so very practically in the inpatient setting, what are some of these practices that you talked about here, or maybe anything else that you're utilizing specifically in the inpatient setting to reduce harm for folks that have a substance use disorder?
Mm-hmm. Yeah, that's a great question. So it really depends on what substances they're using, but I do like to really highlight, especially with our interns who are freshly coming in, to focus on a destigmatizing, non-judgmental, kind of motivational interviewing approach to these patients, just being curious, asking more questions about it, and not discounting people when they say, like, I don't want abstinence, I don't want to go to rehab. We can still, again, meet these patients where they're at and be able to at least offer other treatments. So if they're using IV, offering them, you know, you're already here in the hospital, why don't we go ahead and get some labs? And if you need referral to infectious disease, we can do that. We make sure to provide everybody with naloxone when they discharge, things of that nature. Yeah.
Thank you.
Mm-hmm.
Dr. Richardson, I have a question.
Mm-hmm.
Naloxone has been proven to save lives and make a big difference in preventing overdose. How do you address people who say naloxone is merely, giving people the opportunity to continue using drugs instead of being, they just think it's encouraging people to use drugs rather. How do you answer that?
Yeah, typically I'll talk to them about, kind of as shown in the PowerPoint, like there have been studies that show that you don't see an increase with this, and it does save lives. And these are people, these are kids, parents, neighbors, siblings. So how would you feel if, your person, someone that you love and care about, have a substance use? Wouldn't you want them to be able to have, a rescue option available for them? The biggest thing that I typically hear about is either family members or patients themselves talking about some concern about getting naloxone as, well, that means that you think I'm going to fail and I'm going to use again. So a lot of it is education on that is not what I mean by this. That is not the point of this. The point is that you can save someone else's life, and even just carrying it on you can save someone. So, it's important to provide education to those around us too with that.
I had a question. As far as like the overdose prevention centers, I know you said that they have like additional resources and things like that. Is it like social work essentially, or like what? Or I guess like what other resources do they have?
It depends very much on the centers. It talks more about this on the video. The center sounds absolutely amazing. They have like masseuse there. They have different like zen places where you can sit and just kind of hang out. They have licensed counselors there to be able to, as well as I believe if someone is interested in a residential program or starting medicines for opiate use disorder, they get them in right then, no matter if it's like 12 o'clock on a Saturday night, or if they have mental health or other, kind of illnesses going on, they're able to refer them there, and they kind of keep that all in-house. So it really minimizes people having to go to different places and kind of getting lost in care.
I had a question too. So great talk. Appreciate you coming and doing this. So it sounds like there's a reasonable case to be made for having more of these centers around. And from a humanistic approach, certainly some people care less about that, but monetarily too, just keeping people out of the ER or inpatient or things like that. What's kind of the barrier for more of these popping up?
I think the biggest barrier, especially here in America, is just stigma associated with it. Like, we are now allowing people to use substances. Why would we allow people to do that? And, no community really wants programs like this in their community. However, again, from with that, you actually see kind of a safer community. That's an issue with methadone clinics as well. So a lot of this is still around outdated stigma that we have here.
The not in my backyard approach. Is there any other like movement for somewhere that seems to be receptive that just hasn't like been implemented yet?
Yes, there are. I think California is another one that's been looking into this for quite some time. And I believe it might have been Rhode Island that actually signed something allowing this, but there's been nothing further on that.
Indiana did that. Indiana had an outbreak of hepatitis and HIV when people were using drugs in one county in Indiana. So they were resistant for these programs, and finally they had to give up and say, we'll do this program so that we can take care of our people. So Indiana implemented it in 2005.
So some of this was touched upon with Dr. Hyatt's question, but kind of in your training over at Vanderbilt and kind of looking at the literature in this, just, living in Arkansas during your residency training, and now, what are ways you think Arkansas can do a lot better in reducing harm for folks with not just opioid use disorder, but other substance use disorders as well?
Yeah, that is a great question, especially here in Arkansas. The fentanyl testing strips only recently became legal because they thought that, if people could test, they're going to use more fentanyl, which I don't quite understand that. But yeah, I think a lot of this is just, education, especially to one, our medical school, as well as PAs, anybody involved in medicine, nursing, to be able to talk more with the community, and then be able to do more community engagement. Because a lot of this is not people wanting harm to other people, it's just still stigma and a morality thought when it comes to substance use disorder, instead of it being a medical condition that we need to treat.
Do you, so in cases in the community where someone does overdose and has to use the Narcan that they have, I know sometimes like if you use like fentanyl or something with a longer half-life, you may have to use another dose. So do you typically tell, I don't know how much are in each kit, but do you tell patients like if that were to happen, you have to use Narcan, like you need to still go to the emergency room after that?
Yes, typically I do talk to people about if you use Narcan outside of the hospital, you need to call 911 and the EMS, because with fentanyl, particularly carfentanil out now and everything too, people will go back into it. So that's why it's important to call EMS so that they can be transported somewhere. And I do know they are working on trying to loosen at least some of the laws so that people feel more comfortable calling 911, because the initial thought is, well, now I'm going to be arrested for having substances on me. So they're slowly starting to make those changes on the legal side of things. Okay.
Okay. Well, thank you very much, Dr. Richardson. That
Yeah.
was a great talk.
Yes, thank you, everybody.